All right, well, we'll go ahead and get started. My name is Lauren Moore. I'm the Chief Scientific Officer at the National Ataxia Foundation. And before we get started today, just a couple friendly reminders. You're welcome to turn on closed captioning using the CC icon from your menu. Feel free to chat with under attendees using the chat feature. However, if you want to submit Q&A questions for Dr. Lynch to address at the end of this seminar, please type those into the Q&A feature. Any questions that are placed into the chat will not be answered by Dr. Lynch, so thank you. All right, next slide, please. And today I'm very excited to introduce Dr. David Lynch. He's an attending neurologist in the Division of Neurology at Children's Hospital of Philadelphia, and he's the director of the Friedreich Ataxia program. Dr. Lynch obtained a BS in Molecular Biophysics and Biochemistry at Yale and an MD and PhD in Neuroscience at Johns Hopkins University. He was actually a classmate with my former mentor, Dr. Hank Paulson. So come from the same stock. He has been working on FA for over 25 years and has been very, very involved in many of the clinical trials and clinical research on FA, which he'll talk a little bit about today. So with that, I'll turn it over to Dr. Lynch, who's going to be talking all about Friedreich's ataxia at a very, very exciting time for the Friedreich's ataxia community.
Thank you, Lauren. So I believe everyone can hear me. So let me get my screen up here and get myself to full screen here. There we are. So thank you for inviting me to talk today. Again, we're talking about an introductory aspect of Friedreich ataxia now. I'm not going to be quite as verbose as I usually am, A, because I want to leave some time for questions at the end, and B, if you recognize my voice, you can hear that I'm actually got a little bit of a cold right now, and I'm probably going to try and conserve my voice as much as I can. So only talking about 800 or 900 words per minute rather than the usual 2,000. What is Friedreich ataxia? It's a rare, genetic, progressive neurodegenerative disease. It affects about 1 in every 50,000 to 100,000 individuals in the United States of Caucasian ancestry. The estimate we have is there are about 4,000 to 5,000 people in the United States, and perhaps up to 22,000 people worldwide, with patients largely being limited to Europe, the United States, Canada, Central and South American countries to some degree, and India. There are a few isolated individuals in other countries. It is an autosomal recessive disease. You get one copy of a mutation in the FXN gene from each parent. We call the gene FXN, but sometimes we'll refer to it as frataxin because that's the protein it codes for. To get Friedreich's ataxia, a person must have 2 mutations, one on each copy of the FXN gene. Parents have only one abnormal copy. They are carriers and are entirely clinically normal. So parents of people with FA do not manifest any clinical symptomatology related to Friedreich ataxia. There is, however, genotypic and phenotypic heterogeneity. In other words, not everyone has exactly the same genotype, and not everyone looks exactly the same, although the things are really pretty close, much closer than in the spinocerebellar ataxias. Childhood onset is most common, and presenting early is associated with the most rapid progression. The typical age of onset of FA is between 7 to 15 years. We do meet occasional people who present below age 7, and we meet a whole tail of individuals who present after age 15, probably 20 or 25% of the population. There's an intermediate onset group between ages 15 to 25, and then later onset of perhaps 10% of individuals after age 25. We can show that people who present after age 25 have much milder overall phenotypes and slower progression. Everyone with FA has neurological features. The other feature of the disease will vary between individuals, but everyone has neurological features. So being a neurologist, I'm required by law to talk about what parts of the nervous system are affected, and I wouldn't want to go to jail at the end of today. The first thing, and probably the earliest phenomenon, is the loss of the large sensory neurons, which are concerned with proprioception, where your joints are in space. They tell you how your limb is moving and provide feedback to the brain so your brain can act on that. When these neurons are affected, what a person does is they lose their balance and their coordination to some degree. And the other thing they lose is their deep tendon reflexes. You know, when we tap on your knee and it kicks out, that's lost very early in FA, probably in most individuals well before we meet people. There's even almost a question of whether it's ever there, you might say. That's the earliest place lost, but it's probably not that important in the progressive components of the disease. It's all gone in many individuals before we ever meet them. There's also loss of a particular tract called the spinocerebellar tract, and the way neurologists name things. It's sort of spinocerebellar means going from spinal cord to cerebellum. This is also concerned with loss of balance and coordination, and it too is an early finding. Its loss is an early finding of the disease. You also lose the motor tracts, the ones that come from your brain and go down to your spinal cord to tell you when to move. This is an underappreciated event, probably occurring a little bit before we meet people, but also progressing over the course of time when we see people. There's a loss of a very small area in the cerebellum called the dentate nucleus, which is the primary outflow location of the cerebellum. This is lost over the course of disease. It is pretty close to normal when we meet people, and its progression, along with the loss of the motor tract, are the two key features probably in the progressive component of FA. Loss of the dentate nucleus will give rise to a dysarthria, slurred speech, but no change in the content of speech. So only the articulation of speech. You also get modest eye movement abnormalities, and eye movement abnormalities are not really part of FA. For the most part, people do not have nystagmus, they do not have gaze paresis. It's some very small interrupting events of fast eye movements. In some individuals, they lose vision from loss of the optic nerve, as well as some individuals lose hearing in a very complicated auditory neuropathy, which involves difficulty timing the inputs to each ear. So people will hear, but they can't necessarily say who it's coming from. So they have a lot of difficulties in rooms where there are lots of other people speaking, classrooms, restaurants, places like that. But they will actually hear perfectly normal. Some people with FA have weakness of their muscles directly. It's usually mild. You do not lose muscle tissue. It's what we call a non-degenerative myopathy. So the tissue isn't going away. It's just not working as well. It's fatigable. There's also a relative sparing, I use the word relative sparing, of the cerebral cortex, the part of the brain which is involved in memory and many cognitive elements. So that the cognitive features in FA are not a major component of the disease, at least early. These are the features that everyone will have with FA and will slowly change over time. Other people have other features of related to FA in systemic aspects, which makes FA truly a multi-system disease. In the heart, people get cardiomyopathy, which is a fancy name for heart disease. Initially, this starts out the heart becoming a little bit thick. We call that hypertrophic. And that usually does not cause direct issues, except at times of fluid changing in the body. Later, the heart muscle becomes, that thick heart turns to thin heart, and the heart will become dilated, too big. That's the issue that really gives rise to the end stage issues of heart, where the heart doesn't pump enough. This late part is what leads to morbidity, people being in heart failure, as well as it being the main cause of death in about 50% of people with FA. At any time during the disease, people can get arrhythmias, funny heart rhythms. Usually these arise from the atria. And while they are a very big nuisance and need to be treated, they are not in themselves usually fatal. They're usually relatively easily treated, particularly the atrial fibrillation. People with FA also have endocrine abnormalities, particularly diabetes. About 10 to 20% of people with FA have diabetes. Others are insulin resistant. They don't react as well to insulin. It is both type 1 and type 2. So people lack the normal number of islet cells that make insulin. And then over time, their muscle develops insulin resistance, which is more consistent with the type 2 like diabetes picture. So we sometimes say that people with FA have type 1.5 diabetes. People with FA can have skeletal abnormalities, scoliosis, which will require corrective surgery in about 25% of patients. and pes cavus, which is a fancy name for really high arched feet. It has varying degrees in itself. It in itself is not an issue. There's nothing one really needs to do about it. It's just sort of a skeletal anomaly which is there. Almost everyone with FA is fatigued. That is to say, they're just tired all the time, or particularly with exercise. This affects quality of life quite substantially, and it reflects nervous system function, muscle function, perhaps cardiac function, although the weakest link is weakest to that. Psychological issues, as well as things like sleep disorder, which is the last thing on my list. Somewhere between 10 and 20% of people with FA will have sleep apnea, as well as a variety of other sleep disorders. So these are things which need to be managed in the context of long-term treatment of the disease. What's the genetic basis of FA? The FXN gene codes for a protein we call frataxin. Right out of high school biology, genes code for mRNAs, which are made into protein. All patients with FA have 2 mutations in the FXN gene, one on each of the copies that you have. Almost all of those mutations consist of an insertion of a long sequence of the nucleotides guanine, adenine, adenine, or GAA in the gene. It's in a portion of the gene that does not code for protein, so it's never made into protein. A normal number is less than 32. If you're greater than 32, the gene is termed mutated. It can be as high as 1500. The longer it is, the worse it is. The GAA expansion prevents the gene from making the mRNA that is made into the protein frataxin. So that's a long sentence, but it essentially says that expansion keeps you from making any protein frataxin. The longer that GAA repeat is, the less protein you make. Everyone with FA makes some frataxin protein, but they just don't make enough. It is that relative lack of frataxin, perhaps 5% of normal, which gives rise to the disease. I mentioned there are about 4% of mutations or other things. These are all mutations that keep functional frataxin from being made. So we know this is actually a disease of the protein, because the people who have these other mutations look identical to the people who have 2 GA repeats. So mutations in the gene block production of frataxin protein, which gives rise to the disease. What happens if you lose frataxin? It's a protein that is sent to the energy-producing organelle in the cell, the mitochondria. There it participates in reactions which produce ATP, the molecular form of energy that the cell uses. So essentially, Friedreich ataxia is a disease of selective inability to produce energy. What happens there? The cells grow slowly. I didn't mention, but people with FA tend to be thin, particularly early in life. Cells grow slowly and they don't function well. It also, failure to produce energy makes the cells more susceptible to oxidant damage. Those free radicals, which we hear about causing aging, although that's probably an overstatement, people are more susceptible to those. And there may be also specific abnormalities in order to using the chemical precursors the cell uses for specific cellular functions, so-called metabolic abnormalities. That's still being looked at. But if you simply understand this basic idea, mutation in gene leads to RNA abnormalities, which lead to too little frataxin, which leads to too little ATP. You can think about the 2 easy ways to treat Friedreich ataxia, or at least conceptually easy. Make the mitochondria function better so they make more ATP. You don't have any of these things about oxidant damage. So that's one way. It's downstream from the original problem, not making enough frataxin. But it's certainly a very credible way to do it. The other way to treat Friedreich ataxia, make more frataxin in the right cells. So when you hear about clinical trials in FA, conceptually, there's nothing difficult. It's treating one of these 2 ways, making mitochondria function better or making more frataxin. So I think most people on the call, given that this is directed at patients, don't need to know about how it's diagnosed because you've experienced it. But let's just review that for a little bit. The clinical findings of Friedreich ataxia: ataxia, loss of balance, difficulty walking, loss of deep tendon reflexes, so we tap on your knee and it doesn't go anywhere. That frequently happens well before you go to see a doctor. Loss of hand coordination later. And then later still significant loss of speech abilities. Also, people will have cardiomyopathy, heart issues, which might be heard on physical exam or followed on an echocardiogram. They may have diabetes, which can present floridly with an emergency room admission from getting too dehydrated. And people can have scoliosis, curvature of the spine. Everyone has neurologic diseases. These other three features of cardiomyopathy, diabetes, and scoliosis are most common in earlier onset patients. They are the more severe features of disease. While if you travel back in time 30 years, we'd have to use our clinical judgment to diagnose Friedreich ataxia. Now, diagnosis is made by genetic testing. If you have FA, genetic testing will always be positive for FA. And if you do not have FA, it is always negative. It now defines the disease. And we can't say for certain that you have FA until we see that genetic testing, although we can be pretty sure. In a typical patient, say a 5 to 18-year-old with a slowly progressive loss of balance, no reflexes, doesn't even need to have a family history. Your neurologist is probably the only test they need to send is Friedreich ataxia genetic testing, because that's what's going to be right in that classical individual with the right age of onset, ataxia, and no reflexes. Rarely we will be wrong if we use that guideline, but it's probably the only thing you need to say. Occasionally, people would do other tests sort of to help them get the answer before genetic testing. Nerve conductions, where they take the nerves and they shock them and you measure the size of the sensory potentials. I'm sure the chat will light up talking about how painful that is. Well, we can pass on that in the model there. It doesn't need to be done. It's under extraordinary circumstances. MRI scan. MRI scans are essentially normal in Friedreich ataxia. They will appear normal by the clinical read. Now, if we flog them a little bit and measure everything in excessive detail, you can find some things change. But the clinical read is usually normal. And the only other thing that a person might need to have early is a vitamin E level. That's because if you were born with the inability to absorb vitamin E, you look like you have Friedreich ataxia at first and second glance, not a third glance. So it's okay, but so it's reasonable to send a vitamin E level when you meet someone, because that is a 100% treatable disease. So there probably are a few people who may have gotten the diagnosis but not had genetic testing yet. What does it do? It actually is the direct test for the direct causative GAA expansion for the primary genetic test. It's not testing for a marker, it's testing for the disease itself. And you have disease if you have two enlarged GAA repeats, one on each allele, one on each copy of the FXN gene, frataxin gene. As you go throughout there now, some labs give you the exact size. I mentioned that normal is less than 32, enlarged is greater than 32, but it's better to be closer to 32 than it is to 1500. Some labs will give you the exact size, which can help predict the speed of progression, but not all labs do this anymore because it's actually a pretty hard test and it costs extra money to do that part of the test. So many labs will just report greater than 100 or greater than 165 now. That doesn't keep you from predicting the course. The age of onset is actually a better predictor. We always talk about GA repeats are longer in people with younger onset. But the other way to look at it is younger onset is really the thing which predicts how fast a person will change. That's sort of a way of saying the faster you have changed, the faster you will change. In about 4% of people with FA who get genetic testing, you only find one GA repeat. Only about 1 in 100 people is a carrier for FA in the United States population. So in those individuals, you suspect that they actually have something the genetic test didn't catch. So you expand the genetic test to do DNA sequencing and look for that second mutation, which is one of those 4% of the funny atypical mutations. But you never do the sequencing first because most people aren't going to have it. Most people, it will be negative. Sequencing does not find GA repeats. And perhaps one of the most common errors, I've seen this in at least 3 people, is individuals in whom sequencing was done first and the diagnosis was missed for anywhere between 2 and 5 years. So if you've only been tested by sequencing and they say it's negative, that's not the way we test for FA. You do the GA repeat testing first. A couple other things. There's no need to test parents. They have to be carriers. New mutations in the gene are extraordinarily rare, and I don't even know that one has ever been found. So there's no need to test the parents. They're obligate carriers. If you want to entertain yourself, you can think about the question of, let's suppose one of the parents tested negative. Think about that conversation that follows. I'll come back. You can ask me about it in the chat if you don't get where I'm going. It is controversial to test unaffected siblings. We can find people before they have disease, but do you really want to know? There are good reasons for knowing. There are reasonable reasons for not knowing. So when we come up with this, my advice to people, since now it's frequently done by primary care physicians, do not do the genetic testing without thinking about it first in an unaffected individual. The siblings who are younger and who might have the disease, but you don't know. Well, we are going to have to talk a little bit later about the elephant in the room, the approval of omavaloxolone, and I spelled that correctly. There being a treatment. Now the rules on testing unaffected individuals changes for those people who would get the drug. People 16 and older, if they think they might have a risk of getting it, it is reasonable to test them so that they could go on pre-symptomatically. So that event from last week actually changes the rules on genetic testing to some degree, particularly in the people 16 and over, and this should be 16 and older, not over 16. That also brings us to what we do at the present time. At present, there is no treatment to stop disease progression. Notice I use the word stop. Let's say slow down. There are ongoing clinical trials of many small molecules that target downstream pathways, and now gene therapy and other things to restore frataxin. These are all worth investigating. And then we have last week, OMAV, which I'll talk a little bit more about later, because again, it's the elephant in the room. And I suspect some people are tuning in to see what I have to say about it. The main thing we do is annual evaluations to be sure people do as well as possible. Echocardiograms to find issues in heart failure first, EKGs to be sure people aren't at risk for arrhythmias, glucose screening, hemoglobin A1C screening, be sure you're not getting diabetic. Scoliosis screening, particularly in 7 to 18-year-olds, once you reach your adult height. If your scoliosis is mild to moderate, it isn't going to change. Our criteria for doing interventions in adults are pretty high. So after age 18, scoliosis screening isn't that important. Vision and hearing screening, not so much to treat the FA part, but to look for other things which will make vision and hearing better. Physical therapy, occupational therapy, and speech can help people maintain their abilities. Sleep study on occasion in people. Symptomatic treatments for the stiffness, also called spasticity, the neuropathic pain, the heart failure, and perhaps most importantly, symptomatic treatment for depression. About 20% to 30% of people with FA at least are depressed. And it is responsive to typical medical agents and as well as psychotherapy in many individuals. This is something which is very important, maintaining mental health as well, and even taking the medical approach to it. There's no rule for ongoing MRI scans, ongoing nerve conductions, and really ongoing neurological testing isn't as good as figuring out how to manage someone as asking a person how they're doing. I view you patients in the audience as much better about telling me how you're doing than my evaluation. If you want complete clinical care guidelines commented on by the experts around the world, they are available on the FARO website. So, excuse me there. So for people with new diagnoses, what should you do? I would suggest visiting the Friedreich Ataxia Research Alliance website, www.curefa.org. They have there a lot of resources, chat groups for you to connect with other patients, other parents, ambassador programs for people to get together with and talk about things and have input on where the field should go. They have an FA app personally, I don't do social media. I think most of you know that. I would be a nightmare on social media. But they have an FA app for you to connect with other patients, and they even announce clinical trials through it, as well as actually trying to do clinical trials through clinical studies through the app. And they have a Facebook page, which keeps you up to date on everything that's new in Friedreich ataxia. They also have a new feature, been open for probably a year or two now, which is set up by Lane Rudden, who I have to promo because she used to work in my lab, so I have to promo her, called the Minutes of Science, where she's gone through and done very well illustrated diagrams of the concepts that I've been talking about here, as well as all the research studies that are going on, so you can watch the pictures, really understand them. Next thing I do, I register in the FARA patient registry. Again, find that on the FARA website. Essentially, all the clinical trials we do recruit through this registry. When we run a clinical trial, an email is sent out to everyone from the FARA registry, as well as my own personal registry, who is within the right age group. And then it's largely a first come, first serve. We're proud to recruit clinical trials of 30 individuals in a couple hours, so that we do not have clinical trials fail for lack of subjects. I'll mention most other research studies use the FARA registry as well. And then I would also encourage you to participate in the Friedreich ataxia natural history study. This is a research study. It is not clinical care, but a lot of times you could coordinate with your clinical care and you'll get to see one of the true clinical experts in FA. I will admit we're merging with the European study soon, so the 12 sites in FARA will merge with the European group. I'll mention we have sites in India, Australia, 2 sites in Canada, and then I should say American sites, not North American sites in Philadelphia, Atlanta, Gainesville, Tampa, Columbus, Memphis, Iowa City, Denver, and Los Angeles. I'd encourage you to participate. They have some money for a travel to get there, and it allows you to learn a lot more about the disease and usually ask some questions of the real experts. Other things to do. Participate in clinical trials. We do not get new drugs without clinical trials. That is a requirement. And the FDA asked us to show data that new drugs work. That's fair. So the only way to do it is with clinical trials. Usually in FA, there have been multiple open at one time. At this moment, there are a couple of phase 1 studies, as well as a phase 2 study. Generally, it'll cover many, if not all age groups. You can find them in the FARA website on the resources for clinical trials, which also has some information about how to be a good patient in a clinical trial. It's not always that simple. You can also look at www.clinicaltrials.gov, which is required to have all clinical trials that are recruiting up. And then you can always ask the PIs of natural history studies, so they'll know about that. At this moment, there are active studies on frataxin restoration, giving frataxin back through gene therapy, protein therapy with injection, as well as epigenetic therapy to turn the gene back on. I also encourage you to participate in other studies. We would not get clinical trials to work unless we prove that other tests follow the roadmap of the disease. These studies, called biomarker studies, may be blood studies, they may be functional testing, they may be MRI studies, but without these studies, we can't do clinical trials to find more drugs. So let's now get a little bit, if you went to the FARA website and we're looking up clinical trials, you'd probably end up on this page, the pipeline. These are all the drugs that are presently in development for FA. Left side is the ones that are starting. It starts with discovery, preclinical development, the first filing of permission to get into a clinical trial, phase 1 studies, which are purely safety, phase 2, which are sort of preliminary efficacy but safety, definitive phase 3 studies, new drug applications. So you see that they go in this direction. This is what they actually are designed to do. And you realize this one nice one, which was a filled bar, a white filled bar from Reata Pharmaceuticals, home of Aloxolone. I'm not allowed to say the brand name, so I won't say it. If you use it, I'll respond to it. I recognize it. So OMAV has crossed the finish line. And that was last week, about 6 days ago. It is the first approval in Friedreich ataxia. And it does change, as I mentioned earlier, the rules in genetic testing. We sort of already changed the nature and the hope which is associated with this disease at this point. So I'm going to tell you a little bit about the study, the final study, so that you get a good idea about it and know what to ask your doctors when you go to ask for it. We learned a long time ago that antioxidants are simplistic. Instead, what fluvoxamine does is it enhances the levels of this thing called NRF2, which controls your body's reaction to free radical damage. For some reason, it's turned off in FA. We don't understand that. OMAV turns it back on. That led to a large study, which is now published last year, about 100 subjects, multiple countries, placebo-controlled, as essentially all clinical trials are to get them in many situations. Randomized registration will be designed to get the answer. People 16 to 40, this just tells us it's sort of mid-range disease. And this is how we analyzed it. And this is the data. And I encourage you to be data-driven, because hopefully other drugs will come along and there will be decisions to make. And many of them will be your decisions. Placebo up is bad, down is good. Placebo is in white. This is 3 months, 6 months, 9 months, 12 months. Placebo goes up 2 months. This happens in all neurologic studies. And then it worsens and happens to be the slope is exactly the same as natural history progression. Drug people go up and you see a benefit that endures per year in this case. This whole difference here is the difference of about 1.5 years of disease progression. So one way to conveniently think about it is in starting on OMAV, the average person, I notice I said average, it does not apply to any specific person, will improve their neurologic exam by about 1.5 years worth of progression, whereas a placebo group continued to worsen. That's not bad, particularly when you consider that if you look at it over time and keep people on drug from week 52 all the way out. Natural history data would go along this line right here. These are people who went on drug after the placebo. These are people who went on drug from the beginning. They stay different. The sooner you start, the better it is. But it progresses very slowly. It does progress, but very slowly as compared to natural history data. That's the message to take away from all that scientific information. It's a good drug. Brings people back. Is not a cure. So that's the simple thing that everyone should realize. It's also pretty safe, not a lot of adverse events. There's some things I still don't understand. It's not important to know, but it is important to know that just because you do one study and find something which works some, you need to keep doing more to help things work better so that you get closer to that 4-letter word cure. What have I said in the past half hour? I've left plenty of time for questions. FA is a multi-system disease caused by decreased expression of a single gene, the FXN gene, leading to decreased frataxin. You can use many meaningful treatment to hit one or all of these. We have a good places to go to keep the study up. And now we have omaveloxolone has been approved, but also other things which are upcoming therapy. Remember, though, that each new finding leads to more questions, which is why we have to keep working together to move things forward. So at that point, I'm going to stop my sharing. And I've left plenty of time for questions here, I think. And my voice is still intact, surprisingly. On mute.
Thank you. Thank you so much for that great introduction and overview of FA. So we do have a couple questions coming in, but I encourage all of the participants that to please plug them into Q&A so that we can keep it going. So the first question is there any cognitive issues associated with FA?
Traditionally, FA is not associated with cognitive issues. That said, Jeremy Schmallman's work has suggested that there is a component of the classical cerebellar cognitive issues, and it is not as prominent as in individuals with other ataxias. I'll quote one of my patients who described some of the mild issues of that syndrome and said that if she didn't know, she had just noted them as her personality and didn't realize they were part of the disease until she read about it. It is not a dominating feature of the disease, particularly in the young onset people. And again, it's very hard to study because it's quite late. And you have to normalize, if you're going to study it, you have to normalize for all the other things that go on. Do you have heart disease, which gives rise to its own cognitive issues? Did you have to undergo the anesthesia of scoliosis surgery, which has potential issues? And do you have things like diabetes? So it's very hard to study in FA because it's so non-dominant.
On a related note, can you speak anything about the mental health related problems in children, particularly with FA?
So mental health, as we talked about, is very important. There are several aspects to it, and I'll go overall and then see how it's very hard to study in children. There is probably some selective affectation of the brain affecting mental health in FA. Again, 20% of people clearly respond to antidepressants, and I would say in my patient population at any given moment, probably 30% are on antidepressants. Classical depression, no schizophrenia. There is a late phenomenon of people have called it hallucinations, but I don't think they actually are. I think the main component is what I would call deafferentation. If people do not feel, cannot sense things well, they don't see well, they don't hear well, they will have illusions of what the world is, which people interpret as hallucinations, but they're not hallucinations at all. It's how they actually sense it. In children, it becomes more complicated because children are still developing. And if you live in certain states, the incidence of ADD would be described as 10%. Admittedly, if it's 10%, it's not a disorder, it's a variant of normal. But that's an intervening component. Sometimes people with FA, because they do not know where their limbs are in space, the children will frequently move their limbs spontaneously, a process we call pseudoathetosis. It will be misinterpreted by others as attentional issue. It's not at all. It's a neurological finding. ADD itself is not part of FA. Every once in a while, most recently about 2 months ago, someone will ask whether autism or spectrum disorder is part of FA. I don't think it is, because every time we do the calculation, it's no different than the general population. It's a recognition of how frequent such things have become in society and how much we call them. Depression is harder to get to in children because so many things are going on and there's so much change in their lives and reaction. I think one of the most important things in maintaining mental health is, if a person is worried about it, find a counselor that can help direct you toward strategies for dealing with things, not strategies for analyzing your mom and dad and how they gave rise to things, strategies for addressing the future and its ongoing evolution. That's the kind of counseling which I think is important. And then don't hesitate to tell your physicians, and I will tell you, antidepressants can work. There are chemical components of depression which can be part of FA.
Thank you. And I know it can be very complicated. So there's a couple of questions coming in about, now that there is an FDA approval, how will that affect how clinical trials are run? So
I could go back to the slide, but you notice that people did fall off in the 4 weeks they went off drug. So while the benefit of OMAV is significant, we don't know how long it endures for if you stop drug. Unless there is a drug interaction between OMAV and whatever the drug is being tested, I would expect that the placebo group in most trials will be people on OMAV. That's my expectation. Or another way is you could go on it, they are indifferent to whether a person is on OMAV. So I would expect, and I do not own a pharmaceutical company, so I cannot say this for sure, that the placebo group will basically be the OMAV group, will be people on OMAV. In people who are approved to get OMAV, so 16 and older at this moment.
It's a good segue into our next question, which is what therapies are in line for folks who are under 16 years of age? And do you know anything about the potential for OMAV being eventually approved or tested in 16 or under?
So I did not make the call that occurred with Reata and apparently the patient population after the approval. I was too busy answering things, let's say. I'm told they discussed that they are planning a pediatric study. I'm told, I'm guessing, since one person said they'd watched it multiple times, it's up on the web, the Reata website, I presume. I do not know that for a fact. So listen to what they had to say about it. Obviously, we need to get, it's important to get drugs, and particularly this, to younger individuals. It'll require another clinical trial to assess safety and dosing. I think everyone is looking forward to doing it as soon as possible. The first therapies for children right now. I'm trying to be a little bit agnostic on the vitamin therapies, adebenone, coenzyme Q. Do I believe they work? Yes. Did clinical trials show they work? No. People got better, but they didn't hit the 20-to-1 shot that we're expected to hit at the track when we do a clinical trial. They are safe, so I have no problems with people taking them. They are pea shooters compared to real drugs. I've been told recently that no one knows what a pea shooter is anymore. I'm responding from a different era. I'm 63 for the record. So they're not nearly as potent or efficacious as any of the drugs coming along. The only clinically recruiting clinical trial for children right now is Dr. Shannon McCormick's so-called XREX study. It's a what we call a 2x2 study. There are 2 interventions: exercise, which we know to be effective in FA, at least colloquially, and nicotinamide riboside. You can find it on clinicaltrials.gov or on the FARA website.
Great. So a couple more OMAV questions, if you don't mind. One was about, was there any, did OMAV show any effect on cardiomyopathy?
That's a very good question. The study was not designed to assess effect on cardiomyopathy. You were allowed in it as long as your ejection fraction was 40% or greater. You were not allowed to have unstable arrhythmias. It did not produce any adverse events in the cardiac world, but it wasn't really challenged to do it. Theoretically, NRF2 levels are decreased in the heart and FA, so when you would expect that it would affect the pathophysiology there as well. But that's just it's a basic science finding. You can't say anything about heart.
So now we're going to make a about face. How has the pandemic affected your parents, and affected your patients, and what advice would you give?
So what I would say, the pandemic has, well, it was tough on everyone. It was very tough on people with FA. I didn't concentrate on it today, but clearly in all ataxias, the more you move, the more you move. Your brain simply reinforces what it's doing when it's working best. And if you're not doing anything, you lose skills. There's also an exercise benefit in FA. I'm sure Lauren would love to have Kyle talk at one of these one day, but there's an exercise benefit which occurs in a lot of individuals. Well, the pandemic kept everyone inside. They didn't do that exercise like going to the store to get groceries or going to work. We saw people fall off significantly. And when they started getting back to toward normal lives, they actually started regaining some skills, not magnanimously, but gaining back what they could.
There's a couple of questions from folks who had ataxia onset later in life, 50s, 60s, 70s. Can you comment as to why that would occur in some individuals?
So in the late onset, and presuming these are people with Friedreich ataxia, the age of onset and the severity of disease is predicted by the length of the shorter of the 2 long GA repeats. I follow a few individuals who I met in the first decade of life. Their shorter repeat lengths are uniformly 700 and longer. People who present later in life are a lot closer to that normal number 32. Follow one person at 40, one person at 90, another person at around 80. As a result, the silencing of the frataxin gene is much less in those individuals, so they make more frataxin. They thus are destined to do better. That's not all the story. There are a couple of other genetic markers, like whether the GA repeat is interrupted, and then probably some markers beyond that, but that's probably beyond anything other than talking about it in my office.
Are there any dietary supplements or specific diets that have shown any effect in FA?
So there should be a diet which is ideal for FA. We are not smart enough to know it at the present time. People with FA, we know they don't burn carbohydrates very well. Fat is how they burn fat is an open question right now. A lot of times protein is what people burn. So you should have a diet which is, I'll go out on a limb and say high in protein, but the others are open for discussion. In roughly 1 year, if things go as expected, we're working on this right now, and I hope to have something that we can put into clinical trial roughly 1 year from now.
All right. Do you have any experience with the video games that are based on coordinative training in children with FA? Do those appear to be working?
So my opinion on exercise and on many forms of therapy, physical therapy and occupational therapy can teach you specific things, but a lot of it is the exercise which is best for you to do is that which you like doing. They sent me to medical school to learn things like that. So however you use their hands, whether they're in those video games designed to use coordination, or whether it's simply texting on your phone, which is a pretty precise maneuver that I can't do. Most of you are familiar with my typing and you know how bad it is. The more you use your fingers, the better they will be. Doesn't matter whether you're using that video game or not. If that video game is what keeps you interested, go for it.
We have quite a few folks from up north in Canada who are wondering about OMAV and the approval process in Canada. Can you touch on that at all?
I can touch on it. I would say ask my good friends at Reata. I know it is their plan to try and bring it to all patients around the world. There are complicated decisions there as to where they go first and things like that, and I know it's on their agenda.
What is the status of stem cell treatment in FA?
So stem cell treatment, thinking about stem cell treatment, there are a couple things which will make it challenging. First, it's a lot of anatomic diversity that you would have to repopulate. So even stem cells, which are going in just to restore growth factors and things like that, they're going to have to cover a lot of area, all the way from peripheral nerves all the way to the central nervous system. That's challenging. I will say that I've been unimpressed by the stem cell treatments available in other countries. I've had some patients get them, and the results are, to me, unimpressive. There is a line of investigation with a couple of investigators in California where they're doing systematic stem cell treatments to try and look at some of the FA mice. The data is promising. I remind you that these are mice. Mice are smaller than people. Duh. So the simple scaling up to go to a person is a bit of a challenge, but their data in mice look attractive at this point.
Sorry, a couple more OMAV questions, if that's okay. So one of them is, did OMAV show any efficacy with vision? And was it tested in late onset and show any efficacy in late onset?
So within the study, people in the study did not have significant vision loss on high contrast vision. I could probably actually go back and tell them whether it worked on low contrast vision just by selecting my own patients, but I don't know the answer to that. The retina is part of the nervous system. There's no reason why it wouldn't work, and no data to show that it does. So that's a nice non-committal answer. The second half of the question was vision. What was the other part?
Late onset.
So within the study, there were some individuals who had later onset, 25 and later. The ceiling on the study was 40, had to be 40 before the first dose. So there are some individuals who presented in the 30s. that actually gets to a very good thing. You asked me, did it show benefit? The benefit was a little more in people who were younger. I didn't say age of onset, but were younger. But it was actually about the same. It was just very slightly more. So you expect it happens over the course of the entire disease range. And the second thing is, I can't tell you about any individual, specific individuals, because all the investigators remain blinded. The reason for that is because once you unblind, you can't do any more calculations to get more data. And it was those late calculations of the extension study that took OMAV across the finish line. So it's not unblinded. We can unblind it tomorrow, let's say. I just have to, but because we actually do have the approval now. So now you're not going to do any more calculations. But I can't actually answer that. My perception is that it didn't matter what age of onset in terms of relative response.
I think this will be the last OMAV question, but will the drug be available in all pharmacies or just special pharmacies? And if so, what is a special pharmacy?
So I will repeat what my good friends at Reata, I'm not even using that as a euphemism today, have put forward. It will be available in a single centralized pharmacy through their REACH program. So if a person wants to get drug, you need to have, you fill out your portion of the REACH document, have your physician fill out the other portion of the REACH document, and then send it off to the REACH pharmacy, and then things start happening. What they said last week is that there will be no drug available till May or June. So you do not have to rush out today to your doctor's office. Casually before May 1st will be just fine.
If you have not received genetic testing, but are fairly certain you have FA, is there steps you need to take before seeking OMAV?
Yes, that is one thing. That was an OMAV question. What'd you know? When you send in the REACH form, they ask for one other piece of paper: your genetic test results from an accredited genetic testing lab. So you will have to be genetically tested. That's a little weird because we are running a clinical trial of people with vision loss, many of whom presented originally before the genetic testing era. We had to go back and get them genetically tested again. And if it was done in a research lab many, many years ago in Montreal by Massimo, you may have to go back and get a clinical genetic test.
There is one question about a genetic test, which is, do both parents need to be alive and be tested for Friedreich's in order for you to receive a Friedreich's test?
No, this is a direct test for your condition. You don't have to know anything about the parents. So they test the patient. You don't have to know about the parents. And I encourage people not to test parents. Why? Suppose one parent is not a carrier. I don't want to have that conversation.
All right, moving right along. Why is this question is why is OMAV right now only available to ages 16 and over?
So the simple answer, that's what the FDA approved it for. The reason is limited to that the study only included individuals between 16 and 40. The safety profile in individuals under 16 is not known. It's conceivable that the dose is different. One thing I will compliment Reata on doing, and it adds time to getting a drug to market, is they did a detailed dose response curve. The dose for clinical use is 150 milligrams. If you go to 300 milligrams, the effect goes away. So for people out there who think, oh, that was great, why don't I take twice as much? Doesn't work that way. So you have to know what the right dose is. We don't know that in people under 16. Do I think it's a lot different? Probably not, but you have to prove it.
And then finally, can you speak on what the prognosis of someone who's been diagnosed with hypertrophic cardiomyopathy?
So that's an interesting question. The answer is I can't tell you. Because if you actually, cardiomyopathy, I will note, and this is our fault, is poorly defined. If you took anyone who has simply an abnormal EKG, you would say 90 to 95% of people with FA have cardiomyopathy, but only 50% of people are destined to die from cardiomyopathy. The hypertrophy is, for the most part, not what kills you. It's when that thick muscle turns to thin muscle and doesn't pump well. And that's not necessarily related to how thick your heart is. A person I saw 2 weeks ago never had a thick heart, but his heart has turned thin now. So is having some issues, had to start on some medicines. So the hypertrophic cardiomyopathy doesn't necessarily predict anything. It's the other features. It's a very complicated question. The best predictor of clinically meaningful cardiomyopathy is age of onset. The younger, the more likely. But there are exceptions. So everyone's an individual.
And I think this is the last question, unless there's anyone who's going to throw something in the Q&A last minute. But if someone is trying a new medication, or for example, this person mentions coenzyme Q10, how would you suggest they go about determining whether it seems to be working in them? Is there a certain test that they can perform?
I'd say the test of life. Do you feel better? Are you noticing things in your life that you can do more readily? If the answer is yes, it's by definition working. Even if it were placebo effect, you know, if it helps you, you don't need one of us to tell you if the drug has helped you.
Okay, we do have those 2 last-minute questions that came in. What is the incidence of asphyxia death in FA? Is that a common cause in FA?
So asphyxia death from so the causes of death in FA, it's basically heart disease, hearts that don't pump, congestive heart failure, the sequelae would go at arrhythmias, and then the complications of not moving around, pulmonary emboli, pneumonias, blood clots, things like that. Asphyxia, except as should not be in itself a typical cause unless it is related to global heart failure.
Okay, so the last one, does the ataxia and FA depend on your mood? If you're happy, does ataxia seem to decrease, or vice versa?
My answer is yes. Everything depends on your mood. Whether it's better concentration to be able to do things, or the simple act of being happy, or more interest in moving around, which promotes your motor abilities. So everything depends on mood. Go through life with that request.
Well, thank you so much for getting comments in, saying thank you. This is very helpful. We're right at the end of the hour. So thanks again, Dr. Lynch, for joining us and taking the time to answer our many questions.
Thank you. Talk to you later, guys. Bye.